few minutes, I'm going to talk about acromioclavicular joint injuries. I am Mohammed Imam, based in Surrey, UK. In the next talk, I'm going to talk about acromioclavicular joint injuries, which are very common sports injuries with both acute and chronic presentations. The high rate correlates with more than 100 reported surgical techniques described for management over the years. The anatomy and configuration of the ECJ makes it a resilient joint that can resist a significant amount of force before disruption. Yet, it is one of the few major joints in the body where dislocations can be managed without intervention. In the next few minutes, we'll review the anatomy, biomechanics, as well as assessment, diagnosis, and different treatment protocols, including our preferred protocols for various ECJ injuries. We know that the CC ligament is the strongest ligament controlling the acromioclavicular joint. We all know that it's formed of conoid and trapezoid with tensile strength of over 800 newtons. The anatomic landmarks and isometric point of the CC ligament on the undersurface of the clavicle has been well described. When we wrote this book chapter in the very important textbook, we found that there has been debates all over the years on the best way of managing acromioclavicular joint. However, there wasn't a lot of debate on the dynamic and static stabilizers as well as the biomechanics. For many years, we knew that the acromioclavicular ligament and capsule plays a majority of horizontal stability, whereas the CC ligaments provide a large percentage of supra-inferior or vertical stability. And we know for many years that the deltotrapezial fascia plays a crucial role for horizontal and vertical stability. That's why Fukuda affirmed that if maximum strength of healing after an injury to the acromioclavicular joint is the goal, all ligaments should be allowed to participate in the healing process. But we did that wasn't followed in all the described surgical techniques. We have to understand that the acromioclavicular joint is a subcutaneous joint without a large sleeve of muscle protection. It's more prone to injury mainly because the sternoclavicular joint is very stable. Direct and indirect trauma can cause this type of injuries. However, Tosia and Rockwood have highlighted the sequelae and the cascade of disrupted joints. Starting with the acromioclavicular ligament, then the coracoclavicular ligaments, then the coracohumeral ligament, deltotrapezial fascia, finally, loss of the suspensory support of the shoulder girdle and the shoulder will fall downwards. They popularized their classification, which is widely used. However, evidence did not really support the inter and intra-observer reliability of this classification. Diagnosing these acute obvious injuries is not rocket science, but we have to, because these patients will have sudden pain, cradling arm, obvious deformity, and x-rays might be obvious, but not all the time. In subacute or lower grades, it might be hard to define these injuries. However, you'll find these patients having pain on lying on their side, struggling with overhead activity, lifting, pulling, pushing, and sometimes it might be even so subtle to the extent that only a dynamic ultrasound scan, which was popularized by Petrons in 2007, is the only modality that can differentiate this type of injuries. You might not need an ultrasound scan to manage this, but there are few tips we have to understand. We have to understand that these patients will have limited abduction in most of the time, especially in higher grades. X-rays can be enough most of the time. There is actually no need for MRI scans. And the three tips. Am I going to manage this with surgery? Possibly, yes. Are you going to manage this with surgery? That's a debatable question. Okay, so Let's understand things a bit more. First, as with every other thing in orthopedics, we do not treat x-rays. We treat patients. So treating according to the grade here might not be the best option because we know from previous publications, like this paper by my good friend, Mr. NG, has proved that the reliability of the classification system is not as high as we would like it to be. And so when you see a patient with this type of injury, you have to clinically assess, and possibly your impression and your decision would be completely different here. Second bit you have to understand, and this is an important tip, this is a scapular injury, not a clavicular injury. And that what was highlighted in 2009, that 70% of these patients will have scapular dyskinesis, especially with chronic type 3 acromioclavicular dislocation. And that's why you have to understand the difference between locked and shocked scapula, because complete ECG disruption, especially grade 3 to 5, are clinically obvious with a classical deformity. They might be locked or not reducible as the clavicle overrides the acromion. A locked dislocation may not allow a full scapular excursion, which will lead to a variable limitation of elevation. If type 3s, then these are likely to become type 3B dislocation. However, some complete dislocations may be unstable but can be easily reducible. We call this a shock dislocation or type 3A on the ESICOS classification. Both type 5 and type 3 dislocation behave in this way. We therefore prefer to describe these injuries biomechanically as shocked or locked, as this has a more functional predictability and effect on the management than the degree of vertical translation alone. And the third tip is it's not all about CC ligaments. We know, as from the previous slides, that acromioclavicular joint and ligaments and the deltotrapezial fascia plays an integral and crucial role in the stability of these joints. And that's why the 100 techniques at addressing one of all these variables have failed over the years. And that was proved by Harris, who demonstrated that none of these reconstruction techniques were able to restore the normal biomechanics of the acromioclavicular joint. So that's why I would prefer undertaking what I call the triple anatomic technique, bearing in mind that it's a scapular injury and you're managing patients clinically and not radiologically. In our book chapter, we published this algorithm, simple algorithm. See patients at 1 week. If they are coping, 3 weeks. If they are coping, review them again in 3 months. We call it the coping versus non-coping approach. So for this patient who's obviously not coping, what I'll do, I'll use the Nottingham approach and then address the CC ligament first. My preferred reconstruction technique would be the large ligament with very strong tensile strength that enables me to reconstruct the conoid and the trapezoid in anatomical tunnel compared with the actual tunnels. And then I'll use the modification by the right intermodification of having figure of 8. And here actually in the right intermodification, it's just tying the large ligament ends. Here I actually stitch the ends together and then aim to reconstruct the acromioclavicular joint ligaments. This is the original CL ligament transfer in which it was transferred from the coracoid to the distal end of the clavicle. But the modification we currently do is actually taking the CL ligament from the coracoid and using it to construct the end into the end of the clavicle so that it has a very strong proprioception rule. Another way of addressing reconstructing the acromioclavicular joint would be using the large ligament as well in this fashion in order to reconstruct the ligament. And finally, in all cases, we do deltotrapezial fascia reefing, which we know from 1963, it is crucial for a normal biomechanics of the joint. And finally, you can see the two screws used for the ligament. This is the bony anchor used for the CA ligament transfer. Same protocol for all of these patients. You have to be extra cautious when you see these clavicular fractures. You can see that this was an open fracture where the clavicle end penetrated the trapezium. The fracture was fixed. Large ligament used to reconstruct the CHC ligament. CA ligament was transferred and fixed with intraosseous repair and deltotrapezial fascia reefing undertaken. Patient open fracture healed. 6 weeks after surgery, patient has regained good range of motion. What about failed fixation? Actually, that's a big topic for next meeting. Thank you very much. It's really crucial to see the whole picture. It's really crucial to address the whole problem. Thank you.